This lecture, this particular segment, I think is made a lot easier, as I said, based on our discussion on the first day. Remember we had that huge 20-minute back and forth about opioid use in the ED and who should we be giving pain meds to and stuff like that. It covered about 2/3 of this lecture, which is really nice. So if we can just keep doing that, you guys do 2/3 of the work again. Really appreciate it. It'll be really good. But we're going to go through them anyways, because there is some stuff we didn't talk about. So we'll just start right at the beginning. Question: what is ACEP stated with respect to opioid use for patients presenting with non-cancer pain? So this is a relatively new position statement from ACEP, and it kind of comes down to 4 points. They detail them in a lot of detail in the handbook there, but the 4 points are essentially very anti-opioid from the ED. They're saying, basically, if you have a patient who's coming in with acute pain, think of something you can use besides an opioid. And they specifically refer to back pain. Say, all right, patients coming in for back pain, don't reflexively jump to writing them for Vicodin or Percocet or Norco, whatever it is that we're giving these patients, to think about anti-inflammatories, think about alternative sort of therapies first. And then they make some recommendations talking about Schedule II opiates being more effective than short-acting Schedule III opiates. If somebody knows what the difference between those two things is, they can explain it to me privately after the lecture here, because I'm not really sure. And number 4 is how about chronic pain? What do we do with non-cancer chronic pain? And essentially they say this is not our job. Like, this is not our job to deal with this. These patients should be seen by a primary care doc. They should be seen by a pain management specialist. So this sort of isn't our thing. So they're very, very anti-opiate, publicly so. And this is obviously kind of a hotly debated topic, and we could go around the room saying if everybody agrees or disagrees with that policy, but just so you know, this is what our official organization that speaks for us is saying is kind of anti-opiate in the emergency department. So, all right, now we get into some of the abstracts. So first question, how are physicians using opiates in the ED? This is abstract number 1, intravenous opiate dosing. This is a prospective cohort of 700 ED patients, and basically the take-home message from this abstract is that the most common initial dose, and this accounted for about 90% of the patients getting morphine, was in the ballpark of 2 milligrams. So how do we feel about that? It's ridiculously low, right? There's no way this is going to work. Now, they also looked at the patients who got Dilaudid instead of morphine. So, this is a prospective cohort. And what do you think the milligrams were in the patients who got Dilaudid? About the same, 1 to 2, Question? Okay, generic drugs. So hydromorphone, I know is Dilaudid, and morphine is... Thanks. I'm like, wait a minute. I know it's my last lecture, but don't you torture me like this. All right. Let me ask you, the only other med I'm going to talk about is Dilaudid. Can I just call it Dilaudid now that we know it's hydromorphone? That's the one? Is that okay? If I use a new one, if I know the trade name, if I say it, if I don't, I'm going to very slickly gloss over it. And then and if your hand goes up, I'm going to very slickly ignore that. So just so you know. I'm just kidding. I don't know exactly what the situation is here, why we're giving 2 milligrams of morphine and 2 milligrams of hydromorphone or Dilaudid, because I think it just, for some reason, the higher number, I guess, is a little freaky to us. Like giving 8 or 10 milligrams of something seems like a lot, whereas giving 0.5 milligrams maybe of Dilaudid, an equivalent dose, would seem really small to us. Like it's just a weird gamesmanship thing, but the point of this paper was just it's something to be aware of, that if you're going to give opiates for acute pain, that you should be giving them properly in proper doses. Abstract number 2 is a second study of the same cohort, but now they're looking at it from the patient's perspective, so the same 700 patients, and basically they said after these meds that were given, 60% said they had basically no improvement in their pain at all, which is not surprising because they got these tiny little baby doses. So again, if you're going to give opiates, make sure to give an appropriate dose and reassess the patient at frequent intervals to make sure that they're actually having a positive response to the analgesia that you're providing.
So I was just going to say, we order it, but the nurse's job is to give it, and the nurse will always give it. If you order 10 of morphine, they're going to give 2 or 4. That's what they're afraid.
So
if you order 1 of them Dilaudid, they think it's just a milligram, they think it's equivalent, so they don't mind giving a milligram.
Right. No, I am not disagreeing with that statement. I can't stand up here and publicly say that. I'll repeat it though. These are not my words. That some of the issue is that even if you write for 10 milligrams of morphine, like a nurse sees that 10 milligrams of morphine, like 10 milligrams, I'm going to give 4, and then another 4, and then 2. I'm going to sort of do my own, break it up, because 10 sounds like a lot to me, whereas 1 milligram of this other drug, 1 milligram, maybe I'll give 2. That seems a little small. I agree, it's not always the doctor's perception of that number, but there is some weird perception where we make, in our heads, we make all the different analgesics seem sort of equivalent to each other. So it's like 1 milligram of this is the same as 1 milligram of that is the same as 1 milligram of the other. And that is a problem that needs to be addressed. And if it's a nursing issue at your spot, then that just needs to be addressed with nursing. But and the last abstract kind of changes gears a little bit, and it talks about morphine use after combat injuries. So this one's kind of interesting, and this was done at the Naval Research Center in San Diego. This is about 700 injured military personnel. And these are real injuries. These aren't like boo-boo on thumb kind of injuries. This is like shrapnel, something horrible happened to my leg. These are really, really nasty injuries. And they had a protocol where they immediately got morphine. And the amount of morphine they got wasn't even that much. The initial amount of morphine, now they get titrated up, but they got 5 milligrams of morphine. They're like, oh, something bad happened. Here's 5 milligrams really quick, just while we sort of sort things out a little bit and figure out what we want to do. And they followed these patients up, and they found that in patients who got morphine early, so immediately, right at the time of their injury, even though it was only 5 milligrams, they had a pretty significant decreased incidence of PTSD as compared to those who did not. And I believe this, even though it's small doses of morphine, because we know this to be true in a lot of different emergency department settings, where if you treat the analgesia quickly, the experience of the emergency department and the stress that they take with them afterwards tends to be significantly less. So this is just another reminder, another way of saying the same message, which is give appropriate, adequate analgesia and give it early. Give it as early as possible. The next question says, what's in a word? Narcotics versus opioids. So what is the difference between a narcotic and an opioid? That's exactly right. So those are the two correct answers. Narcotics sound bad, and there's a social stigma. There's actually no difference, right? And we're talking about the same thing. It's just for some reason, people tend to equate narcotics with sort of a street drug, and opiates as a medication prescribed to them by a doctor. And that's what's addressed in this next abstract, where they looked at 100 patients, and basically they asked them a series of questions about, do you think these drugs are legal? What are they used for? Blah, blah, blah. But in half of them, they used the word narcotics, and in half of the patients surveyed, they used the word opiates. And what they found was overwhelmingly, when the word narcotics was used, they're like, oh, narcotics? Oh, yeah, that's a street drug. That's a street drug. People abuse that stuff. I know exactly what narcotics are. And when you said the word opiates, a lot of the times people were like, opiates? I don't know what that is. I've never really heard of that before. I guess that's some fancy doctor medication. That sounds really cool. Maybe I'd like that. So I think the take-home message here was that we as physicians should be calling them opiates, not narcotics. We shouldn't say like, hey, give me the narc script, give this guy some narcs, narc, right? So we shouldn't do that. We should call them opiates. And we should explain to the patient what they are, what they're used for, and these are medical drugs to treat your pain. Okay. The next one is, this is really funny. This is a funny abstract. How does patient behavior impact pain management? And the title of this next one basically says everything. This is abstract number 5. When you dislike patients, pain is taken less seriously. So what they did here was they took 40 volunteers, and they showed them pictures of 6 different people who were all in pain, right? They looked like they were like grimacing, they were doing things, they were all in pain. But next to each picture, they had a series of adjectives. It was like, motherly, homely, kind, gentle, or it was like jerk, angry, agitated, right? So just a picture, and this isn't even a video, it was a picture and a little bit of a word description as to what these patients were kind of saying, little bubble, what they were thinking, right? And what do you think the volunteers did for those patients? I said, all right, well, you can see they're in pain. They're grimacing. You want to give them pain medications? The groups who were the jerks? No, they're fine, right? And the ones who were like, oh, your Mother Teresa? Oh, poor baby. Let's give you as much opiates as you need, right? So they were much more willing to give narcotic opiates to patients who had friendly words associated with them than those who were jerks. And do we do this in our practice? Guilty as charged, right? But it's one of those things we have to be cognizant of. It's very difficult to stop doing immediately, but we just got to remember that jerks, in truth, probably get into more painful situations than non-jerks do, right? So they maybe even need these things more. And number 6 tackles a little more provocative thing, which is looking at racial disparities in pain treatment. So what they did here was that they did 3 different studies that they published in one paper. In the first study, they showed 2 different black patients and 2 white patients, pictures, having pain to 50 white subjects. And what they found here is that the white subjects were much more likely to give pain medications to white patients than they were to black patients. Now, they did a second study, a follow-up study. Same group of people, same pictures, half white, half black, all white practitioners, but they showed them an empathy video first. So nothing to do with race. Nothing to say like, hey, be cognizant, don't be racist, don't do that stuff. Just that pain is a serious condition. This needs to be taken seriously. We as emergency practitioners need to be aware of pain, treat pain appropriately. Don't forget about treating pain. And then they showed the second group the same set of pictures. And how'd they do here? Much better. They treated the groups exactly equally, right? And they repeated the study again with nurses and no empathy videos, so not just, now I say, okay, well, let's not just look at MDs, let's look at nurses as well, and they found the same thing as the first study, which was there was a racial bias that was there. So I think this study points out something that we know, we don't like to admit, but there is a little bit of racial bias in the way we practice, and the way, potentially one way to sort of desensitize ourselves to this or be better about it is not even to think of race, but really just to be reminded that we are supposed to be empathic. We are supposed to be thinking about things from the patient's perspective. So I like this paper. It's kind of weird the way it's done, obviously, but the message is very clear and I think very poignant. So the next question, the literature has indicated inadequate pain treatment for at least 15 years. Is pain treatment improving? This is one of those, again, where if any of you has ever listened to any month of EMA, and you've heard Rick and Jerry talk about this, you'll know the answer to this question. Are we getting better at treating pain despite beating ourselves over the head about it at every single conference that we go to? No. The answer is no. So there's a series of papers here where they talk about sort of the most marginalized, trivialized groups, which are non-whites, the elderly, kids, and the cognitively impaired. Those tend to be the big 4 in whom we don't do as good of a job in giving analgesia. And abstract number 7 is basically a chart review that emphasizes the fact that white patients with same injuries were more likely to get analgesia than non-white patients. Number 8 talks about pain documentation and how well we're doing on this. They looked at 6,000 patients, and they found that pain scores were documented in 3/4 of the patients, but we didn't use analgesia in almost any of them. And the last one is emphasizing the kid issue. This is abstract 9. So this is a chart review of just over 100 adults with appendicitis and 40 kids with appendicitis. So same disease process, and they found that in the adults, about 80% got some kind of opiate to treat their appendicitis pain, and in the kids, what percentage do they got opiates to treat their appendicitis pain? Yeah, like 1/4, so 25%, much lower. So it's just emphasizing that point. Remember those 4 different groups: the elderly, non-whites, kids, and the cognitively impaired, because they really need pain medicine.
Those are all the high-risk groups to give pain medicine. If you start off at 0.1, have a problem with that. You give it to someone who's 40 that otherwise has no problem. Same thing with the children.
Oh, we have disagreement. I love it. Go. Rebuttal, 30 seconds.
I do that routinely with everybody. I've never seen anybody stop breathing from narcotics. I give them 0.1 milligram per kilogram. There's a starting dose and another dose and another 20, 30 minutes if the pain's not controlled.
Counterpoint.
I don't agree with him.
Yes.
Then you've not practiced long enough. We can even order it like that. Why give 8 off the bat?
So I will say this.
The thing is, a lot of these people, I have a lot of people that don't want to be stoned.
Yeah, I will say this as I try to be the mediator of these 2 halves of the room, is that I think that the issue really is we're talking about 2 different issues here. One is quantity, and one is giving anything at all. Right? What these papers are saying is we are not doing anything. We are giving them 0 analgesia. Both sides of the room can agree that is a problem. 0 analgesia for a patient with a painful condition.
That's obviously one of the core measures we're looking at because of CMS and everything.
But I'm saying just
But there are a lot of patients when you ask them whether they want something, unless you don't document.
That's exactly right.
On the chart, when they do a chart review, they think you didn't address it.
So I think that was going to be sort of the way I would say is that this is a great time to involve the patient and the patient's family. And I almost always do this with painful conditions, regardless of what it is, because everybody has different personal thresholds of pain and different personal thresholds of the side effects that they're willing to accept with the pain medications that they're given. So I often say, you have this, I can use this, I can use this, I can use Tylenol, I can do nothing. You know, like here's the pros and cons of all of them, what do you want? So that's one great way to handle it, and I do that very routinely in my own practice, but it's very important, like you said, to document it, right? Analgesia types discussed with patient, they said they prefer this or nothing or whatever, and so that's what I did, right? But not discussing it at all is a mistake. That to me is very clear. Now, in terms of the dosing in the elderly patient, you know, like you were saying, you tend to go a little more gingerly. I do the same thing in my practice. And I feel very comfortable with this because I know that we can say over and over again the therapeutic dose of morphine is 0.1 milligram per kilogram, right? We can say that until we're blue in the face. But the reality is we know a lot about morphine, and we know that the best way to give morphine is not to bolus them with 0.1 milligram per kilogram. It's to do small boluses and titrate up rapidly to effect. So every 5 minutes, start with a milligram, 2 milligrams. 5 minutes later, go in, having pain? No, give you 2 more milligrams. Another 5 minutes, still breathing, not having pain, give them another 2 milligrams. There's lots of different ways to sort of tackle the same problem. I don't have a problem going a little more gingerly in the elderly, and mainly because my issue is I feel like they get the adverse, not even just stop breathing, but they get very nauseous, they feel really sick when I like jam 8, 10 milligrams into sort of a little patient who's a little bit on the older side. Dr. Henry. So first of all, I'll say this. I am not describing some kind of utopia that I work in. For those of you, like a lot of times I get to sit up here at the ivory tower and say like, oh yeah, it's 3 in the morning. Oh, just call the IR attending to come down and do stuff, right? Because I do have that luxury you guys don't have. Now this problem you're describing actually may be worse where I work. I work at a very busy county hospital, and if the nurse is going to reassess the patient every hour or two, I feel very lucky. So I hear you. I'm not sitting up here saying, this is how it works at my place, and this is how I write my orders, like give morphine 2 milligrams every 5 minutes. What I'm trying to do is describe what I think is the best practice and a best way to do it. Now, whether or not you can actually enact that is up to you, and I think that's why we tend to go with the bolus, right? I remember I used to work at a really busy community hospital where almost any painful condition, the first thing you write on the chart, you wouldn't even write it. The nurse would say, Ash, should they get the 10 and 10? You say, yeah, give them the 10 and 10. And that's 10 of morphine and 10 of Reglan. Like, you didn't even see the patient, you know? I mean, that's like kind of how it worked there because it's busy, and you knew the nurse wouldn't be able to get back to sort of do this slow, gentle titration. This was more of an advocate on my part for saying, hey, if we can try to get, like yesterday there was a little bit of a discussion about PCA or something like that, some way to actually get this done, even though it's a big pain to set it up. But obviously highly controversial topic. I think that the points here are if you're going to give morphine, give enough. Regardless of, enough is different for different patients too, right? Like if I had a painful condition, it would be very different than if Greg had a painful condition for reasons that I will not disclose. Nothing. Just mind your business in the back.
0.1 per kilo, by the way, only works in half of our patients.
Right, so he's saying is they need like a lot more. And again, this varies by patient population. Some patients it'll work great, some patients it won't. But you should know that if you're going to give a patient pain medication and you give them 1 milligram of morphine and walk away and don't come back to them for 2 hours, the chance of that working is very, very slim if we have already made the decision that opiates are an appropriate choice for that patient. Comments would be that we know that pain has sort of a wind-up effect, right? So the more C fibers, the more nociceptors that get activated, the more difficult it's going to be in the long run to control that pain. So untreated pain, as it gets worse and worse, gets exponentially worse and worse and difficult to treat. So chasing your tail is a problem, but giving 2 milligrams of morphine every 5 minutes is not chasing your tail. That is totally appropriate. Nor is giving a big bolus up front. That is not chasing your tail. That is totally appropriate. But letting them sit there in the waiting room for 3 or 4 hours with nothing and letting more and more pain fibers get activated, now we are going to be chasing our tail when we finally decide to do something about it.
I think this is a great discussion, and I agree. Pain well means
So I think your point is very valid, and it was intentionally sort of left out of this chapter because that really is a discussion in and of itself, like how to deal with the patient who is the drug seeker, right? Because we can sit up here and preach all day and all night that we need to treat pain appropriately, we need to treat it aggressively, but that does require us being a little bit of judge, jury, and executioner, right? So everybody's gonna have to set their personal threshold of what they want to do, and for me to say like what is the correct way to do that, I think would be a gross oversimplification of a very difficult problem that we face as a specialty. So it's good to be aware of it, but everyone's gonna have to come up with their own strategy, I think, to deal with it. Totally agree. And like I said, and prescription narcotics, I think that's why it was left out of here. We're sort of talking about NED, IV treatments to acute painful conditions, which is very different than talking about prescription narcotics for chronic conditions, right? With that, I do believe is its own 30-minute lecture. Apparently, even this is its own like hour-and-a-half lecture, like what's in here. But a very important topic, but talking about the prescription side of it versus the acute dosing in the emergency department, I think are two really different discussions. I just don't want to muddy the waters too much. And I want to attempt to at least get through some of these abstracts, because some of them are quite interesting. I'll sort of, since I know I'm already over time, but I don't mind continuing. It's my last lecture of the whole course. So. A few things they really want to mention here is they talk about, kids with long bone fractures. This is a study of almost 400 kids with long bone fractures, and only half of them got any type of analgesia at all. Right, it's just a sort of reminder again about these marginalized populations. And then they say, well, what if we, mandate pain scores? They talk about this. Let's have every patient who comes into triage, regardless of their chief complaint, get a pain score. So you'll see like heart rate, blood pressure, O2 sat, temperature, pain score. Right, so there's a few studies in here where they talk about hospitals that implemented those protocols, and when they implemented the pain score protocol, what happened to the use of analgesia? Went down. It goes down in almost every study that looks at the same thing. The goal obviously is, well, if you put it like a little vital sign, like you put it right up there with the heart rate and stuff, that we as emergency physicians will then act on it like a vital sign. But we don't, right? And the reason we don't is because we know that pain scores are dumb, right? It's not a vital sign. It's not a heart rate. Like, we have often seen the patient where they say pain score documented as 10 on the chart. You walk into the room, they're reading a book, they're kind of hanging out, and I get it. A 10 is different for one person than it is for another, but I think that it caused errors in two ways. One is you see that too many times. You see a 10, 10, 10, 10. You walk in the room, and they're as comfortable as can be, legs crossed, hand behind their head. Then it starts to get in your head, this pain score is stupid. It doesn't mean anything. And other times, there is a flip side of the coin where patients are too scared to say they have too high of a pain score. Right? They may be in a lot of pain, but they actually may say, like, really, I said 2, I'm okay. Like, go take care of some sicker patient or something. It's hard to believe these patients exist, but they do. Right? And that's borne on the literature. So then we may do the opposite. We may say, oh, well, they're only a 2. I'm not going to worry about it. So know that pain scores kind of have some utility, but not a big one. The next one is, there's 3 abstracts here talking about vital signs. So if we say, okay, I can't trust them. I can't trust these people. I can't trust anything they're telling me. I'm going to look at their heart rate and decide who's actually in pain. People with pain should have a high heart rate. Does that bear out? Absolutely not. And there's 3 pretty well done abstracts here that all say that. And then the last question I think we'll go through is, this is a very significant question, is what is the impact of ED crowding on pain management? And what do you think it's good or bad? Oh, bad. Oh, that was pretty easy, right? So, but how bad is bad, I guess, is the question. And there's 2 abstracts here that kind of say the same thing. The first one is 1,000 patients with abdominal pain, and they basically found that there was a significant delay to the dosing of analgesia when the emergency department was crowded by a bunch of different metrics that they used. But in this particular study, they found that all the delay was in time to room. And once they actually hit the room, the time to analgesia was about the same as when it wasn't crowded. This isn't my experience at my hospital that I work at. My experience is more like the second abstract, which is a chart review of over 1,000 patients. Again, they used a bunch of metrics to look at how crowded the place was, and they found that the time to analgesia for painful conditions was significantly higher in crowded situations not just the time to room. And I think this is realistic because in crowded situations, we're not getting in there as quickly. The nurses are very busy and they're overworked. So, these two are, we get it. Like at the very beginning, everybody said, it's going to be bad. Crowding is definitely not going to be good in terms of our time to anything, but it's nice to have lots of documentation of this in the literature, I think. So when we start having to fight weird political battles about staffing and things like that, we have some hard evidence to go by. So I'm already over. I'm not going to take any questions, but I'll be hanging out for the next 15 minutes. And thank you guys. Really enjoyed the course. So. Oh, shoot. The one thing I totally forgot about. So just an announcement, general announcement. Hemel is an RWJ fellow, so he's obviously a very smart guy, and I've known him since he was an intern up at UCSF, and he is doing a study looking at emergency department physician opinions about something. I won't tell you what. I won't let the goose out of the bag, but if you guys don't mind, it's like a 3-4 minute study. If you have just a minute and you get like a little Starbucks gift card and you have Hemel's eternal gratitude, and someday when he's writing all these papers, you guys can feel like you were there for the beginning, the very first moments of it. So if you don't mind, that's Hemel. Raise your hand again, Hemel.